to begin the panel, I first want to make kind of 3 observations about provider competition and consolidation. And then I'll introduce our guests here, and then we'll proceed. The first is that for about half the healthcare in this country, the prices are determined via markets. So, understanding how those market forces are working or not working is going to be particularly important for cost and potentially quality outcomes. However, many healthcare markets and insurance markets are rather concentrated. According to the HHS, about 83% of folks living in MSAs are in concentrated hospital markets. So that's in concentrated being Herfindahl indices above 2,500. And markets are becoming more concentrated. So from 2008 to 2012, market concentration increased by about 8% across MSAs. So it's a pretty big increase in a relatively small period of time. So that's on the hospital side. On the insurance side, those markets are also concentrated, perhaps not as concentrated as the hospital markets, but still concentrated, and enough so that the American Hospital Association has put out reports expressing their concern about the concentration in the insurance markets. Now, finally, there's been a rise in vertical relationships between hospitals and physicians, whether via merger, via other some type of affiliation. And physician markets and physician practices are becoming bigger. So there's generally consolidation and linkages occurring in the markets that are new. So that's kind of observation 1. Markets are important and concentrated. Observation 2 is that the ACA is playing an important role in, potentially an important role in increasing concentration in these markets through their promotion of accountable care organizations. Accountable care organizations, I think everybody in the room has a good idea what those are, but just for point of reference, accountable care organizations are networks of physicians and doctors that share risk, financial and medical risk for a given population of patients. The goals of an ACO is to coordinate care across these different care modalities. And one important question is how much integration is necessary for those efficiencies to be achieved if they in fact are achievable. And then finally, the third observation I want to make is that there's been increased antitrust enforcement. The Federal Trade Commission has brought 3 cases in the last several years, one in Toledo, one in Rockford, Illinois, and most recently in Boise, Idaho. And they've prevailed in all those matters. And those have sent important signals to providers about the feasibility of consolidation. And then, of course, even more recently is in Massachusetts, the Attorney General in Massachusetts has reached a settlement with partners over their merger to their acquisition of South Shore Hospital and Hallmark Hospital. And there, the settlement there is very different than we typically see in antitrust settlements. It's a conduct remedy, and I'll talk a bit more about that later on, as opposed to a structural remedy. So to me, these 3 observations imply that, one, that the healthcare sector is going to be an important focus of competition policy, and that competition policy is going to be particularly important in affecting the welfare of all Americans going forward. To start off, I'm going to maybe put Mike on a little bit on the hot spot, but the FTC seems to have recently stepped up its enforcement profile in the healthcare provider space. So I wonder if you could provide some insights into what was behind those decisions, and maybe you can describe a little bit of the sausage making that led the FTC to start to look into these matters and take maybe a more aggressive stand.
Sure. Before I say anything else, let me give the obligatory disclaimer. Anything I say here today are my opinions, not those of the FTC. What we do now, I mean, right now, I would say, there's not any conscious decision that we're going to go after any particular set of mergers. We take them as they come to us. I mean, when firms propose to merge, they have to notify the Department of Justice and the FTC of their intention to merge. We take a look at it, and if we think it's a transaction that threatens competition, we initiate an investigation, and if we think the evidence shows that it in fact would reduce competition substantially, we challenge. And Bob mentioned some of the court challenges that we've successfully brought. And there's also been a number of cases where we threatened to bring a court challenge, and the parties abandoned the transaction. So we've been very successful. We've also, as Bob mentioned, we just had a case involving actually a physician merger case, St. Luke's in Boise, Idaho. But again, we're just applying standard antitrust principles as sort of presented and articulated in the DOJ FTC merger guidelines. When we see a case, a transaction that threatens competition, we go after it, and that's true in every market, not just hospitals.
And Aviv or Mike, maybe either one of you can answer this. What are kind of the key lessons that you've learned in these cases, bringing these cases forward, as far as how to think about competition in hospital or physician markets? Kind of what did you not know before that you know now, and now that you take into account in your analyses? Well,
there are a couple of things I think that we learned, and I think the courts have learned as a consequence of what we've been doing the last 10 years. If you look back, if you went back and you looked at the reasons why we were losing cases in the 1990s, we lost often because of geographic market questions. Judges would look at transactions. Frequently, transactions took place in big metropolitan areas, and they'd conclude, look, there's 1 million hospitals. There's no way the merger of these two hospitals can threaten competition. I think the Evanston case and some of the other case studies that we did the Sutter Summit retrospective analysis that we did. It's a big merger case out in San Francisco. Again, we found substantial price increases after the fact. And I think what those studies showed is that even when mergers take place, seemingly in a sea of competing hospitals, you can still have dramatic anti-competitive effects. So that's one thing. Another issue that's important in healthcare markets and hospital markets in particular is the role of not-for-profit providers. Again, we lost some of those cases because the judges looked at the transaction involved two not-for-profit entities, and the judge would conclude, they're not out to maximize profits. So the standard model that you would apply in a merger of, in some other sector of the economy where profit maximizing incentives might lead to a price increase, that's not present in hospital markets. Well, again, I think the Evanston case, as well as some of the other studies that we've done, one of the studies that I did before we embarked on this retrospective project showed, no, you can get pretty substantial anti-competitive effects even with not-for-profit providers.
I really do think, what's changed, obviously it's, what's actually happened in the market, whether it's particularly the Evanston study or that retrospective now. So just the idea that, you see the atmospherics have really changed, right? Prices have increased, academic and research by the agencies have actually been able to relate part of that increase, maybe a substantial part of it, to increase in concentration. So I think that changes just the atmosphere of, when you go into court and how courts are thinking about it. The other really big change, I think, is something that Mike touched on, is I think the agencies figured out what's the right analytic framework to examine these mergers, right? So they really changed the framework by which, markets were defined, in which competitive effects or the concerns from the merger were expressed, and courts bought into it. Bob actually has a significant role both in kind of setting out that framework and also getting courts to buy into that. And that, I think, has kind of been a real significant change.
So, Kate, what from kind of the outside of the agency perspective, from the academic perspective, kind of what do you see the impact of this increased enforcement having on markets?
So I think, Bob, as you said at the beginning, I think this increased success of enforcement has really sent signals to the marketplace, and things are changing. So there was this huge hospital merger wave in the 1990s, over 1,000 mergers from 1994 until today, and things really slowed down once this antitrust enforcement became more successful, sort of from 2005 onwards. Now, you also said mergers have picked up in recent years, and that's certainly the case. So in 2010 and 2011, there was more than 160 mergers of hospitals. So there's a question about why that's happening, and I suspect, excuse me, that's what we're going to be talking about next. There's a lot of other things going on in the marketplace that are leading to these kinds of mergers. That doesn't imply that the enforcement isn't working and isn't sending signals.
Now that you brought up the issue, maybe you could expand it. What do you think is going on? Why are we seeing an uptick in consolidation?
So I think it's clear the Affordable Care Act is changing incentives in a lot of different ways. And we've talked already a bit about accountable care organizations, once you ask a group of providers to take on responsibility for a large group of patients, a large number of patients, and to bear some kind of risk, you're giving them incentives to merge. We're going to see mergers of physician groups. Often these ACOs contain hospitals. You're going to see mergers of physician groups with hospitals. So that's one set of mergers. And then once that part of the market has changed, that's going to generate incentives for hospitals to merge with each other. If there are a couple of very large provider organizations in a market, nobody wants to be the independent hospital that's left out. So that's going to generate more incentives for more changes in market structure. And I think that's what we're seeing in the marketplace now.
So how do the agencies assess the efficiencies in these kind of vertical, horizontal, cases? Maybe Aviv, you can speak to that. Like, how do you go about, assessing whether there's a real case for efficiencies in this merger, or whether that's just a veil to hide the true motives, which are, market power?
So I think these mergers actually have two main challenges, actually on both sides of the equation. So typically when you analyze a merger, you see what are the potential harms, and you try to sort of look at what are the potential efficiencies, then you try to offset those and see, are the efficiency large enough to offset potential harms, and you get something that's potentially pro-competitive. In these transactions, I think both sides of the equations are actually hard to analyze. We have an analytic framework that's been solid and tried for several decades now, looking at kind of traditional horizontal overlap, right? When you have a consumer that's making a choice between option A and option B, you say these guys merge, that's going to make the consumer worse off. But the question is, how do you think about cases where the choice is not exactly, you're not thinking of, am I going to go to this physician or to this hospital, right? It's a little bit kind of more complex than that. And really the choice ultimately is really about, choosing maybe some networks of, that you subscribe to. And it doesn't fit, as kind of narrowly defined view when you're just looking at the harm. So I think that's the first challenge of sort of how do we expand the traditional way of looking at horizontal mergers when we have a very kind of narrow definition of overlap, which we do, for example, if there's two hospitals that are on either side of the street, they want to merge, you can see how that's going to take away two close competitors, right? I'm using hospitals, but you could easily put in gas stations, supermarkets, any other type of product in there. It's kind of the same type of analytics. But here it's different. So that's part of the equation. Now, the other part, and that's the part you ask about, is, well, how do we assess the efficiencies? And it's especially difficult because it's a new model that everyone's moving to, and we don't have a lot of experience with it, right? And we don't actually know what will be the outcome. Will this be, when we look at this 5 or 10 years from now and say, oh yeah, this was this decade's attempt at, I don't know, HMOs or whatever it is that you want, as an unsuccessful attempt to reach efficiencies in the sector, or maybe this is a solution. I mean, you don't know. And the difficult part for the antitrust authorities is the fact that on the efficiency side, there's a lot of uncertainty, and you have to decide how am I going to credit that uncertainty and what is it that I'm going to use. But on the harm side, again, there's an issue of what's the analytic framework, but if you allow the merger to go through, it's very hard to then go back and kind of unscramble the eggs.
So you alluded to kind of the analytics of kind of these vertical mergers being a little bit different than traditional antitrust. So can you maybe walk us through kind of what you see as the potential harm, given that physicians and hospitals merging, they do different things. They're not in the same product market, yet they may raise kind of antitrust concerns and may harm welfare. Can you maybe walk us through a little bit of what the thinking might be along those lines?
So one is to think about what's the analytic framework, kind of what's our model or our theoretical model, thinking what could be the harm. But the other is to try to actually supplement that with data to see in cases where you did see these types of merger go through, what were the effects? What was the harm there? So I think, the thinking is that when you have physicians and hospitals now potentially bargaining together with payers, they actually have more leverage and are able to get higher rates. Okay? The same is true when you have two hospitals that are close substitutes, because if they're bargaining separately, the payer can essentially play each of them off against each other. Okay? But it's the fact that they're bargaining together that gives them more leverage and ability to get higher rates. So I think that's the concern in terms of being able to get higher rates from insurers, and then those get passed through to consumers in higher healthcare costs.
Let me just say, there's that, but there's also just a more straightforward, sort of a traditional antitrust story that's sometimes told in these vertical transactions involving physicians and hospitals, and that has to do with the flow of referrals. I mean, a hospital, it needs to have physicians referring patients to them if they're going to stay in business. And the story that we sometimes hear in some of these investigations that we've done is, look, when this transaction takes place, the acquiring hospital is going to have so many employed physicians now in the relevant market that there's not going to be enough independent physicians left to refer patients to the competing hospitals. And so ultimately, the vertical transaction or the vertical acquisition of the physician practice by the hospital ultimately leads to a diminution in competition among the hospitals as the rival hospitals are disadvantaged due to the loss of scale stemming from the potential loss of referrals. So that's sort of a more traditional antitrust foreclosure story that is frequently told in these cases.
And I kind of want to go back a little bit to the efficiencies of these types of transactions. Maybe, Kate, you can talk a little bit about kind of what we know, what the literature says about the efficiencies of these kind of transactions, and what do we know?
Excuse me, there is not a huge amount of evidence on that, and that's part of the problem, I think, that when you think about these sorts of foreclosure questions, you can flip that around and say exactly this flow of patients from a bunch of physician groups to a single hospital is what's going to create the benefits of these mergers also. That's what's going to lead to a large amount of information in one organization that will reduce duplication of care and improve quality and all of those things. There is not a lot of evidence, as far as I know, in terms of what the benefits have been of particular mergers of this type. There certainly is evidence on particular organizations that are very successful. Kaiser is one that springs to mind that is a large, entirely vertically integrated organization, including the insurer and hospitals and physician groups. Certainly there's evidence in papers that I've written, among others, that they're a terrific organization. They have high quality, they have relatively low costs, and they're very popular in some markets. That doesn't mean that if you allow hospitals and physician groups in other areas to merge, Kaiser is what's going to appear. So I think really the evidence is limited, and that's part of what makes the antitrust guys' job so difficult.
So I think I have a couple thoughts. One is that there's sort of a thousand flowers story here. Like, we need to innovate, and we need to have different types of organizations sprout up and be tried and see if they work or perhaps don't work. But if the antitrust agencies are kind of squashing all of these different kind of experiments, how can we learn, and how should that be taken into account in the analysis? I mean, maybe by preventing these mergers, we're preventing another Kaiser from forming, or another Geisinger clinic, and so how should policy take that into account?
So let me make one comment on that. I think Aviv's previous comment is exactly right, which is that once a merger happens, it's very hard to undo. And related to that, my sense is that a lot of the benefits of these vertical mergers can be realized without actually merging. So Kaiser, in fact, is not fully vertically integrated with its physician groups. It just has exclusive relationships with those groups. Could we not set up similar structures in markets where the organizations are saying they want to merge, just set up exclusive relationships instead?
Yeah, could I just amplify exactly what Kate just said? I mean, I think the FTC and the Department of Justice, and they've made this clear in their policy statements on ACOs. We're very open to a variety of different organizations that firms might try to create to see, to find out exactly what kind of model works best. And I'm sure there's more than one that will work best. But and CMS said the same thing. But the ACA did not repeal the antitrust laws, and so we're still obligated to when some sort of transaction is proposed that we think threatens competition, to demand proof that the efficiencies that are claimed will be realized, and that there's no less restrictive way to get it.
Let me kind of put two hats on. I mean, one is you could say as a social scientist, you might say, hey, we want some experimentation. Let's try different things and see what it works, so then we could look retrospectively. But I think from a public policy, if you think, randomizing just for the sake of learning and seeing what works, I don't think is going to lead to the right public policy, healthcare or more generally. I think the right approach to do is, I think, really touching off where Mike left off, is to really say, you know, the burden, and this is both the legal burden, but I think also just in terms of how the agencies analyze these mergers, the burden of efficiencies is on the parties.
Just setting a cap of 125% of Medicare prices for all provider prices. Just cap it, and we'll have price cap regulation. In part because I think there's this frustration that antitrust agencies have not been successful in preventing, you know, provider groups from accumulating significant market power. So what's your take on that sort of policy? What do you see as the upside? What do you see as the downside? Maybe start with Kate and we'll work our way back.
So coming back to one of the comments Mike made, there's a question about quality, right? You can cap prices, and assuming you can measure prices and somebody will enforce that, maybe that will work in terms of controlling costs or containing costs to some extent, but then there's an issue about what happens to quality. I could imagine a system where price was capped and providers had to compete for patients on the basis of quality. That's actually been done in the UK, my homeland in some sense, and seems to be working pretty well in terms of giving hospitals in particular incentives to improve their quality just to attract patients while prices remain regulated by the government. So it can work, but I think there are a lot of ways of setting price caps that could be problematic in terms of the other incentives that providers have to do other things, like improve their quality.
I completely agree. I think, you know, in a kind of simple world where you're selling widgets, something that's very simple, you could say, okay, you know, price is observable, you can look at that, you know, there is some appeal to regulation, although it has both its, you know, pluses and minuses. I mean, you really want to get things right. And typically, actually, our move is away from regulation. If you look at, you know, the airline industry that used to be regulated, been deregulated, some other industries. But I think, you know, the healthcare industry, I mean, just having simple rule of, you know, Medicare plus, you know, 25% might not be the right answer. I think you might need to, even if you're going to attempt regulation, try to do it in a more sophisticated way.
Yeah, I mean, I think every economist is very uncomfortable with that degree of price regulation, and especially in the case of Medicare. I mean, there's substantial questions that have been raised by MedPAC, for example, about, you know, Medicare's ability to set prices appropriately for specialty care versus primary care, and that's of course just part of what would be regulated under this kind of global price cap. So it would make me, you know, I'd be very uneasy about that.
And so I think what I would want to do now is actually open up the discussion to the audience and have you participate and ask questions of the panelists.